now. So the second part, we are going to see the differential diagnosis by different site of knee, that is differential diagnosis of knee pain by anatomical site. We are going to divide it in 4 compartments that are anterior, posterior, medial, and lateral compartment. So by each and every compartment, we are going to focus with we are going to focus on each and every compartment of the knee separately so that we can I can help you out in narrowing down the structures that can be involved. So, although it may be difficult for the patient with anterior knee pain to be very specific while pinpointing the area of the pain, but we need to be very particular about asking the patient where the patient pain is being felt by them, right? Because it gives an important clue to which structures it might be affecting or it might be involved. For example, retropatellar or peripatellar pain suggests that it goes towards patellofemoral joint. And if there is lateral pain localized to the lateral femoral condyle, it goes towards IT band syndrome. And the inferior patellar pain implicates patellar tendon or infrapatellar fat pad syndrome. So in anterior knee pain, as you can see on the slide, the most common conditions that we see in anterior knee pain are patellofemoral pain syndrome, chondromalacia patella, patellar tendinitis, quadriceps tendinopathy, patellar bursitis, patellar subluxation or dislocation, Osgood-Schartzer lesion, and Hoffpad syndrome. See over here on the patella, over here, we can go for patellar tracking disorder, osteoarthritis, chondromalacia patella, patellofemoral pain syndrome as such. But if the patient is complaining of pain on the upper region of the patella, right, superior part of the patella, then we can go with suprapatellar bursitis can be there, or the inferior part, in the inferior part, infrapatellar bursitis, Hoffmann-Pads impingement are more prominent to be there, right? But if the patient complains of pain near the insertion site of the quadriceps, it may be because of quadriceps tendinopathy, or we can here you can see in the middle side it can be plica syndrome. So these all conditions can be seen on the anterior aspect of the knee. Yes, they can also be seen on the medial aspect of the knee, but they can also be obviously, since knee is a dynamic structure, there may be some uh, symptoms, there may be some conditions that overlap. So, but basically, you can see all these conditions on the anterior aspect of the knee. In the posterior knee pain, as I said, we are going to divide it into 4 segments. For the posterior knee pain, it is mostly now in posterior knee pain. It is seen that the pain is usually referred from the lumbar spine and from the patellofemoral joint, right? And sometimes it may be because of the local structures like popliteus, bicep femoris tendon, which may cause posterior knee pain. Sometimes what happens is that knee effusion can also cause posterior knee pain. So these are the major causes. Other than that, it is seen that the most prominent is Baker's cyst, obviously special injury and hamstring tendinopathy that can be seen. So here you can see the hamstring tendinopathy and snapping bicep femoris tendon can be palpated over here. If the patient complains of pain at this site, we can go for hamstring tendinopathy. We can suspect hamstring tendinopathy or snapping of bicep femoris tendon. Then over here on the proper posterior of the knee, we can see there are chances of Baker's cyst, popliteus tendinopathy, meniscal injury can also be seen, or a PCL tear, then tibiofemoral arthritis. Sometimes the tibiofemoral arthritis pain is also referred to the posterior side on the inferior part over here below this part. We can see we can go for gastrocnemius tendon pain. Then mostly it is gastrocnemius pain over here, which can be felt. Then if there is strain in the gastrocnemius and the soleus muscle, it can be felt over here, right? In the middle of the calf. But since we are focusing on the knee specifically, we'll just go with hamstring tendinopathy, Baker cyst, and OA, tibiofemoral OA, and gastrocnemius tendon pain as such. Coming to the lateral compartment of knee, it is mostly seen in athletes. We can say mostly in runners, to be very specific. In runners, it is a mostly it is seen in runners. The most common cause of lateral knee pain is IT band friction syndrome. The repeated with repeated knee flexion and extension, the IT band wraps around the femoral lateral femoral epicondyle, which leads to IT band friction syndrome. But other than that, we can see lateral collateral ligament sprain, lateral meniscal tear among the other conditions. So in this slide, you can see that if the patient has IT band pain syndrome, the pain will be over here in the lateral femoral epicondyle area. The patient will be able to pinpoint over there. And quadriceps tendon can be felt over here, as we have discussed before prior, that the pain in the quadriceps tendon can be felt in the and can be seen and palpated in the anterior compartment of the knee too, and it is overlapping with the lateral compartment, so it can be felt over here also. Patellar subluxation pain, the patient pinpoints over here, and the lateral collateral ligament injury or lateral meniscal injury can be felt over here. Okay, I hope I made it clear. Coming back to the medial knee pain. Medial knee pain is less common than anterior and lateral knee pain, but we can see that in the medial knee pain, mostly it might be because of osteoarthritis, then middle ligament sprain, medial collateral ligament sprain, medial meniscal tear, pes insalis bursitis, medial plica syndrome. These are the main causes for medial knee pain. In this slide, you can see the hamstring tendinopathy pain. The patient will be able to pinpoint the pain over here. Then patellofemoral pain, osteoarthritis of the knee, then medial meniscal, medial collateral ligament pain on the medial joint line over here. Patient will be able to pinpoint it. Then pes insaris bursitis just below the joint line over here, and gastrocnemius strain tear, which can be felt over here, right? So this was according to the anatomical site. There are some conditions which are more frequently or commonly seen, but we are not able to differentially diagnose it properly. When it comes to diagnosis, we are not able to properly differentiate between the two. So I have prepared a slideshow for that, so that we will be able to properly differentially diagnose it. As you can see, the most common conditions that we see in a day-to-day practice is PFPS, patellar tendinopathy, IT band tendinitis, and ONE. IT band IT band tendinitis and ONE. So first, let's begin with patellofemoral pain syndrome. See, some conditions, as I said, are very frequent in some age group. So in the previous slide, in the beginning, beginners, in the beginning slide, we had segregated the conditions according to the age group. And in the and for PFPS, we are seeing it the most adolescent and adults are more frequently, most commonly. PFPS is mostly seen in adolescent and adults, right? The patient complains of retropatellar region deep pain with which is diffuse aching, and it increases while squatting, kneeling, climbing the stair up, right? And if you ask the patient always says it has been slowly increasing, right? So the onset is seen gradual. With we can see patellar maltracking in these patients because of the tightness of the lateral structures of the knee and weakness of quadriceps, specifically VMO and glutes. The gold standard diagnostic imaging for PFPS is MRI. And in this patient, we can see the positive Clark sign is positive and patellar grind test is positive, right? So in patellar tendinopathy, which is also called as jumper knee, is also seen as adolescents and teenagers also. So it is usually more seen in the inferior pole of the patella, as we have seen in the anatomical side of the uh, anatomical as we have seen in the differential diagnosis according to the anatomical side, right? So the main difference between this is ki it is seen that in patellar tendinopathy, it might be the pain might be gradually increasing or it might be sudden. The patient complains of um, pain after repetitive jumping or repetitive load on the joint, right? The main sign and symptoms are on the palpation of patella and quadriceps tendon. The patient complains of pain. Then there is obviously quadriceps weakness because it is a patellar tendon injury, tendinopathy, and the diagnostic imaging for it is USG and MRI are the gold standard diagnostic imaging. Then special test. If we see the special test, the palpation of patellar tendon attachment, RIC, and single leg decline squat test are positive. IT band tendinitis. As I said, it is usually seen in adults who are mostly runners in sports people, right? The pain location is on the lateral compartment of the knee. The patient complains of aching type of pain, which is sudden on onset. And the patient can see the tenderness over the left femoral epicondyle. Tightness of TFL is seen with gluteus maximus. Excessive foot pronation is seen with genu varum, right? And MRI with MRI is the gold standard thing. IT band tendinitis. It, as I said before, that adults are more prone for IT band tendinitis. It is usually seen in runners, in sports people, specifically in runners. The patient complains of pain on the lateral compartment of the knee with the pain, aching, with aching type of pain. And the sign of symptoms are tenderness over the lateral femoral epicondyle. It is usually seen there's tightness of TFL, gluteus max, and excessive foot pronation. Patient sometimes also has genu varum. If you go by diagnostic imaging, the gold standard one is MRI. Ober's test and Nobel compression test are usually positive. ONE. When we talk about ONE, the age group for over age group for ONE is older adults, right? Older people, older generation. So around the age of 55 to 70 years, the patient complains of pain on the medial joint line, right? Because of the stresses that are there on the medial compartment of the knee. Patient complains of dull aching pain, patient pain while squatting, while climbing up the stairs, climbing the stairs while walking, and they often complain that pain is gradual, slowly increasing, and worse after some time, right? Crepitus can be Crepitus is one of the most crepitus is one of the most common symptom with loss of range of motion. Patient always complains of stiffness in the early morning. That is a sign of degenerative change, which is present in OA. The gold standard diagnostic image for quadriceps for gold standard diagnostic image for ONE is X-ray and MRI. Here, the bounce home test and Clark's is positive. Okay. that was it. But one more thing I want to add up, that in patellofemoral pain syndrome and patellar tendinopathy, right? How are you going to one more thing I would like to add, but the difference between patellofemoral pain syndrome and patellar tendinopathy, how are you going to identify it, right? So pain while running that gradually worsens or more likely to be of patellofemoral origin, right? The pain during running that gradually worsens is more likely to be of patellofemoral origin, whereas pain that occurs at the start of activity and settles after warming up and returns after activity is mostly patellar tendinopathy. That's how you differentiate between the two. Coming back to some other important structures or important diagnoses that are usually seen in our clinical setup, that is ACL injury, MCL injury, and meniscal injury. So in ACL injury, as we have already seen in the history part, the forces that apply that are being that are usually see that are the forces that are usually there in ACL injury are no non-contact deceleration force, that are step, that are quick stops, valgus stress, hyperextension, patient complaints of deep central pain, okay, and patient complaints of pain while walking, while weight bearing activities. There is sudden onset of pain, and the critical sign that the patient can give you is that they heard a if the patient complains that they had heard a popping sound while the time of injury and there was immediate swelling or tenderness around the joint line, that is a common or most common symptom for ACL injury. The diagnostic imaging is MRI and X-ray, which is the gold standard MRI. And the special test for ACL injury are latchman test, anterior dogger test, and pivot shift test. When come to MCL injury, MCL being one of the most dynamic ligament which has overall role in the knee, is more prone to injury. So the valgus stress to a partially flexed knee can cause MCL injury. Patient complains of pain in the medial aspect of the knee with difficulty in knee flexion, right? A sudden onset is there obviously because of trauma, and the patient complains of tenderness at the medial joint line. Then minor valgus instability is there at full extension. When the patient is in full extension, there is minor valgus instability. The diagnostic image is gold standard MRI again. And then we do the special test for MCL injury is valgus stresses at 30 dB. Meniscal injury, when we talk about meniscal injury, there are two types of stresses that can there are two types of stress that can there are two types of stress which can be identified from the mechanism of injury: the shear stress with knee inflection and the compression with femoral rotation. So the location of the pain is dull aching. Usually patient complains of dull aching to sharp and piercing kind of pain, right? There is pain in end range extension and flexion. Patient complains of difficulty in crossing the legs, pain while crossing the legs, then pain while walking, right? And suddenly twisting, pivoting. Then the onset is sudden, obviously, and gradual too, because the onset is sudden or gradual. Signs and symptoms. Mostly the patient complains of tenderness over the joint line, difficulty in extending the knee, swelling after 12 to 24 hours, and intermittent locking because of it is a meniscal injury. The prime sign or symptom the patient can give you is the locking of the joint, as we have previously discussed it, right? The special tests which are positive are McMurray test, Apley's grind test, bounce home test. So that was it according to the anatomical site. that was it according to differential diagnosis for from anatomical side. Nextly, we are going to see differential diagnosis of knee pain according to the structures involved. So when we talk about structures, we are talking about articular structures, periarticular structure, osseous structures, neurovascular structures, and referred pain. So when you're talking about articular surfaces, we are talking about when we are talking about articular surfaces, we are mostly talking about arthritis, chondral lesions, if the meniscal tear, neuroplasia. In arthritis, if the arthritis is inflammatory, degenerative, or infectious, plays an important role in diagnosing the type or diagnosing the knee pain. Periarticular structures. And then second one is periarticular structures. This is when you're talking about periarticular structures, we are talking about tendinopathies, bursitis, cyst, ligament sprain or ruptures. Ligament sprain or ruptures. In tendinopathies, we are talking about patellar tendinopathy, hamstring tendinopathy, quadriceps tendinopathy. Bursitis, as we have discussed, is according to the anatomical site, patellar bursitis, infrapatellar, pes or popliteal bursitis. Baker cyst in the posterior Baker cyst in the posterior compartment of the knee is more common. So that also comes in periarticular structures and ligament sprain or ruptures. When we talk about osseous structures, we're talking about fracture in the patella, tibial plateau, that is a proximal tibia, uh, fibula, tibial condylar. I'm so sorry, there is a mistake in the slide. That is fibula and tibia femoral condyle. Infectious, we're talking about osteomyelitis, neoplasia, primary bone tumors, metastasis. Coming to next, we are talking about neurological or nerve trapment structures, which we mostly miss while taking the assessment or while comparing. Coming to the neurological structures, these are the structures which we usually miss while we are assessing the patient or uh, differentially diagnosing the knee pain. The neurological structures of nerve trapment should also be excluded. The neurological structures, nerve entrapment structures should also be excluded while we are diagnosing knee pain. So when we talk about neurological structures, we are talking about femoral nerve, obturator nerve, and common peroneal nerve, which should also be checked. Coming to the last, referred pain. When we talk about referred pain, we have to see that the pain, as we spoke earlier, that sometimes the pain in the knee can be referred from the spine, right? From the lumbar spine. So we need to exclude or we need to clear the spine first, then the hip, before concluding that it is a knee pain. Sometimes what happens is the pain is referred from the hip or lumbar region, but we uh, diagnose it as a knee pain. So that gives patient a temporary relief and the root cause is not properly diagnosed. So we need to look into it. Then vascular structures. So when we talk about vascular structures, we need to look for a vascular necrosis and occlusive vasculopathy, that is peripheral vascular disease. So sometimes that can also lead to knee pain. So that's it from my side. Let's have a quick revision. We spoke about introduction. Then we spoke about differential diagnosis according to the history. We had segregated the knee pain. We have segregated the knee pain according to the different age group, like which are the conditions that are more prominent in the younger population, that are children and then adults and older population. Then mechanical symptoms that you need to ask the patient, like if the patient has heard any popping sound or something like giving away or something. So, and if the patient has any episodes of giving away or locking of knee, we had discussed. Then we had discussed about the effusion, the duration of the effusion that the patient had after the injury. Was it rapid, early, or slow, rapid, slower, or recurrent effusion? So that gives an idea about the differential diagnosis of the knee. Then the mechanism of injury, which we usually miss, or we don't actually miss, but we usually don't go in depth or analyze the forces that are acting on the knee at that time. So we need to look into it too. Then we had discussed about the knee pain. We have segregated the knee pain according to the different anatomical site. We are divided into anterior, posterior, medial, and lateral. And the conditions that are more frequently or prominently seen according to the anatomical site. So the patient is pinpointing you in that location of pain. If the patient is pinpointing the location of the pain, you need to be very particular about the structures that are present at that anatomical site. So you'll be able to differentially diagnose it properly. Then we had seen the difference between the common conditions that are being seen, like IT band, IT band tendinitis. We have seen IT band tendinitis, patellar tendinopathy, then PFPS, ONE, ACL, NCL, and meniscal injury. We had even di- uh, then we have even diagnose the knee pain according to the structures involved, that were if the patient has any articular, periarticular, osseous, the neurovascular structures, or the pain is referring from hip or lumbar spine, that needs to be seen. If the pain is referring from lumbar or hip, that needs to be screened out or ruled out prior giving the treatment for the knee. But because sometimes what happens is that the pain is usually referring from the lumbar and the hip area, which is not usually looked into, and the diagnosis for knee pain is not done correctly, and the patient has temporary relief, and we need the root cause, and the patient has temporary relief, and the root cause is not done, and the root cause is not properly uh, treated. That's it from my side. I hope you are. I hope you must have understood the knee pain. You can drop down in the comment section if there are any doubts. Thank you so much for your time.